Hi, thanks for joining me. We're going to be talking today about cancer-associated thrombosis. Quite a fact-heavy session, this one, rather than case-based, but it's a really important topic, so I thought I'd make a video on it. So why do this? Well, thrombosis is a very big cause of morbidity and mortality in cancer patients, and these, of course, one of the largest patient groups that we deal with. So your annual risk of thrombosis in your general cancer population is 0.5%. And that's at least 5 times higher than in your general population. And throughout their course, it's estimated between 4 and 20%, depending on what study you look at, of the cancer patients will experience a thrombotic event. And the outcomes of the thromboses are generally worse than in the general population for various reasons. So the reasons that they get thromboses is multifactorial. Venous compression from tumours, indwelling lines increase the risk. The prothrombotic state from cancer cells, there's a lot of fairly poorly understood biology around this. An example would be tissue factor expressed on malignant cell surfaces, inducing the clotting cascade. Endothelial damage from chemotherapy. If we think back to Virchow's triad, one of the things is localized damage that can induce thrombosis. Lots and lots of other factors, but the point is there's a variety of reasons, and these include the reasons why people may have got the cancer in the first place. If they're morbidly obese, smoke 40 cigarettes a day, these of course are going to increase their thrombotic risk. So we're going to talk about what used to be done and then update it with what we're now doing. So as of 2003, the norm was to use low molecular weight heparin. This was on the back of a study called the clot study. And what this did is pitted dolteparin against warfarin and similar drugs called vitamin K antagonists. And it looked at these patients to see which one was better at stopping clots from coming back. So recurrent DVTs and PEs in people on warfarin and such like was at 15%. This was compared to just 7% on dolteparin. So that gave definitive evidence that low molecular weight heparins were superior to vitamin K antagonists in treating cancer-associated thromboses. This is something of a game changer. So the standard treatment since then has been patient gets a PE or a DVT, given 6 months of low molecular weight heparin, and then decisions are occasionally made on long-term treatment after that. And VKAs are used in those who refuse to have the low molecular weight heparin or in selected patients with severe renal failure, but your standard of care would be low molecular weight heparin. So if we fast forward to the present day, I'm sure most of you are aware that DOACs have revolutionized our treatment of thromboses. They've pretty much taken over, and recent evidence is now pushing us towards using them in cancer-associated thromboses. So we've had 3 trials so far looking at edoxaban, rivaroxaban, and apixaban, showing that they're non-inferior to low molecular weight heparin. 2 things to note. First of all, dabigatran is not on that list. And the second thing is that the studies were powered to look at inferiority. So they weren't powered to say one is better than the other. Okay, so if the trials had been designed differently, then perhaps we might be able to say DOACs are better. But what we're saying here is that they are at least as good. So the recurrent rates are at least as low as low molecular weight heparin, but the bleeding rates are higher, and this is a really important point that we're going to talk a bit more about. Subpopulation analysis on these trials found that this was mainly due to GI and GU malignancies, so bleeding from the gut or the genitourinary tract. And we know that especially with GI cancers, your risk of having a bleed is much higher. So let's have a look at those bleeding risks in a bit more detail. So in edoxaban, the major bleeding risk was 6.9% in edoxaban against 4% in low molecular weight heparin. And again, subgroup analysis, that was mainly due to GI cancer patients. The rivaroxaban trial found a similar difference in major bleeding, 6 versus 4%, but in non-major bleeding, so your minor bleeds, there was a much bigger event total in the rivaroxaban arm. This also does show that there was a high proportion of GI and GU patients in this trial when we've done comparisons. The apixaban trial had 0% of major bleeds compared with 1.4 on low molecular weight heparin. If that sticks out to you, it sticks out to me as well. It's thought on analysis of this paper that population may have been lower risk, and there is another apixaban trial ongoing to try and see whether this was a fluke. So what does all this mean for you and your patients? It means we can now use 3 of the DOACs for treatment of cancer-associated thromboses. So that's apixaban, rivaroxaban, and edoxaban. For the patient, it means fewer needles, which for someone undergoing chemo or having nasty side effects from their drugs or their cancers, that could make a big difference. And it means fewer complications of low molecular weight heparin, so you can get localized hematomas and infections and heparin-induced thrombocytopenia. You do need to be wary of the drug interactions with chemotherapy agents and antiemetics especially. So you should always double check with the pharmacist or use the interaction checkers which are available on Insight. We have some special populations to consider as well. So first of all is the major contraindications to using these. So which patients aren't we going to use them for? So high risk malignancies for bleeding really. So your GI and some GU cancers. So my rule is I don't give them at all to patients with GI cancers. For GU cancers, I do it on a case-by-case basis. Someone who's got low platelets with a clear bleeding pattern, I would avoid. Whereas if you've got someone that's had no bleeding issues at all, then you may well consider a trial and you can always switch. Patients with severe intractable vomiting, it's not rocket science. If they can't keep the tablets down, then give them an injection instead. Patient refusal, of course, and unavoidable drug interactions. So again, another reason to use that interaction checker. So other populations, catheter-associated, so patients with indwelling Hickman lines or PICC lines. We're not using DOACs yet, use low molecular weight heparin. We just don't have the evidence yet. In a few years, I'm confident we will be, but not yet. Patients with thrombocytopenia. So if your platelets are over 50, feel free to treat as normal. If the platelets are under 50, it may still be safe, but you should discuss with the hematologists on call. Those with clot extensions on DOACs. So this is a bit of a tricky situation. So let's say you've got a patient with a DVT that's scanned, the symptoms aren't going away, so they're rescanned, and that clot in the leg is actually getting bigger and bigger despite being on a treatment dose DOAC. What would you do then? With this, we'll switch to low molecular weight heparin, and that's because it's a lot easier to tinker with the doses. So low molecular weight heparin, as you know, will be weight-based dosing, and we can tinker with percentages on this. So for example, someone on 15,000 units once a day, we could take them up to 10,000 units twice a day or even further. A lot more difficult to do that with the tablets, especially when we don't have as much experience doing it. Do it under advice, of course. So long-term management of these patients. So we're going to treat them for 6 months for a DVT or a PE, that's standard. If the cancer is still active, so metastatic cancer, or they're on sort of a slow-burning long-term treatment for their cancer, then you can risk assess, but generally we treat with full doses indefinitely with DOACs. The reason I've made a point of saying that is because with non-malignant patients who need long-term anticoagulation, we have started reducing to lower dose DOACs, but we cannot do that in cancer patients yet. But watch this space. So let's look at prophylaxis. So for your standard cancer patient, we don't give thromboprophylaxis. If they're inpatients and they're unwell, then yes, of course, you follow the standard guidelines. But for ambulatory patients, we don't do this normally. There are a population of patients at high risk that we may well consider it in, and we can use something called the Khorana score. And if we do decide to anticoagulate these patients on a prophylactic basis, we'll use low molecular weight heparin. We're not using DOACs yet. So this is the Khorana score. And what this is a little list of things that tell you, is someone really high risk? So let's say you have a patient with stomach cancer, that's anemic, has a high white count, and is got a BMI of 40, then you may well want to consider giving them prophylactic low molecular weight heparin. That's it. So further reading, there's a really good article. If you type in ESMO and how I treat cancer-associated thrombosis, really good article. The trials are quite useful to look at. You don't need to have an interest in anticoagulation for this. If you're learning about research, these are actually really good, well-written trials to help you learn about study structures. And as I mentioned, there's a second apixaban study ongoing, which may well affect how we treat some of our patients. So thank you for listening.